I'm Dr. Sairah and I'm going to take the lecture on ECG made easy, and it's our day one. So today we will be discussing the graph paper, the leads, and the wave formation and the rate calculation. That is the heart rate calculation or pulse rate, and then the rhythm identification. Okay. Okay, starting from the basics, like what is ECG? ECG, as you know, it's the electrocardiography, that the recording of the electrical activity of the cardiac muscles or the myocardium in the graphical form. So I will show you the electrical activity of the myocardium can be recorded on a graph. Its uses, just let's go through it quickly. The primary cardiac illness can be diagnosed. The secondary cardiac illness due to any other pathology, like secondary to the respiratory illness, and then respiratory pathology can also be identified on echocardiography, and then electrolyte imbalance. Now, this is a typical ECG, as I hope you all will be familiar with this picture, the waveforms of ECG and this graph paper. I will first elaborate the different parts of the graph paper, and then I will elaborate the different parts of the ECG and different waveforms. ECG graph paper. There are large boxes, as you can see. These are the large ones, and then there are the smaller ones. So these this one large box has 5 small boxes, or you can say this large square has 5 small squares. Now each small square is about 1 mm in size, in width and height. And if you measure it in seconds or in time, then one small square is equal to 0.04 seconds. And thus, these 5 squares, small squares, or this one large square will be equal to 0.20 seconds. Now here, you can see that this is a large square, as you can see, and it has 5 small squares. And this small square is equal to 0.04 seconds. And this last square is equal to 0.2 seconds. And further elaboration, okay, there are the horizontal axes on a graph, and then there are the vertical axes on a graph. First, I will tell you the horizontal one, and then I will take you to the vertical axis. On the horizontal axis, like on this side, all right, and the vertical is like this. Got it? So on the horizontal axis, the one small square, as you can see, this one is equal to 1 mm or is equal to 0.04 second. And then if you count these 5 small squares, or you can also say this a large big square, is equal to 0.2 seconds. And then these 5 large squares, these are large 5 squares, although these are 4 here, but anyways, the 5 large squares will be equal to 1 second. And then if we go for the vertical axis like this, so in the vertical axis, this small square will be equal to 1 mm, and that will be equal to 0.1 millivolt. I will take you to the next slide for more elaboration, like this one. Now here, as you can see again, then there are the horizontal axis on which we take time, and then there is a vertical axis where we take voltages. Let me draw it for you again. This is the vertical axis, and then this is the horizontal axis. Here we take time in seconds, and on the vertical axis we take voltage. All right. Now, as we take time on the horizontal axis, so these small squares the one small square will be equal to 0.04 second, and these 5 small squares, or you can say this one large square, will be equal to 0.2 second, and the 5 large squares will be equal to 1 second, which means going up here, if you can see this, the paper speed. Now, when I say the 5 large squares are equal to 1 second, it means that the ECG paper speed is set at 25 mm per second, which means 5 large squares have to cross in 1 second. We set ECG paper by default at 25 mm per second. You don't need to go in detail like why we do that. Let's just keep it simple that the ECG paper speed is 25 mm per second, which means actually in 1 second, 25 small squares, or you can say the 5 large squares have to cross in 1 second. All right. So these are the horizontal axis. Now coming to the vertical axis. So vertical axis, we take voltage. As you can see, 1 MV, like 1 millivolt. So one small square is equal to 1 mm and 1 mm is equal to 0.1 millivolt. One large square that will have 5 mm or 5 small squares, it will be equal to 0.5 millivolts. That will help you later to diagnose different arrhythmias or the AV blocks. All right. So we won't waste our time and we will go to the next slide. So this is a final repetition of the ECG graph. Like it runs at a speed of 25 mm per second, which means that 25 small squares or 5 large squares have to cross in 1 second. All right. And then each small square is equal to 1 mm. Again, 1 small square is equal to 0.04 second, and 5 small squares or 1 large square is equal to 0.20 seconds. All right. Okay, now we will go to the ECG electrodes and then we will go to the leads. All right. Some of you may call these as leads, but these are not actually leads. These are actually ECG electrodes. All these have different shapes and different colors as per the company make. So, but we will go for the standard ones. Now, shortly, I will tell you very briefly about the electrodes placement and the colors. I hope you would be familiar with the read your green book thing. Let me use the other marker, sorry. Okay. Read, oops, sorry. It's not red. Okay. It's read your means yellow, and green, read your green book. We have learned this when we were doing our house job. So read your green book means R for red, read your, Y for yellow, green, and book, B for black. Now, the important thing is this black one, we do not count it because the black electrode is usually neutral and it doesn't give you any recording of any electrical activity in the heart. So there are the limb electrodes like these, red, yellow, and green. And then there are the chest electrodes which are placed on the different sides of the chest, or you can say the precordium. So the red one is placed on the right side, R for red. All right, R for red and R for right side. Then there's a yellow one that is placed on the left arm or left hand or the left wrist. And there is the green one that is placed on the left foot. And all these three give you recording of the electrical activity going on in the heart. And these are known as the limb electrodes, and they will give you limb leads. I will tell you later what is the leads and what is electrodes. Okay, now coming to the chest electrodes. Now these chest electrodes, as the name indicates, we have 6 chest electrodes, V1, V2, V3, V4, V5, and V6. So V1 is placed on fourth intercostal space on the right side of the sternum, V2 on the left side of the sternum in the same fourth intercostal space. V3 is usually put on the rib, and V4 to V5, V6, these are placed on the fifth intercostal space. Now, as you can see that V4 is placed on the mid-clavicular line, while V6 is placed on the mid-axillary line, and V5 is in between them. And the chest electrodes will give you the recording of the electrical activity going on in the lead V1, 2, 3, 4, 5, and V6. Now, the main thing is coming, that is the leads. Now, I will tell you what are the leads. Okay, we have 12 leads. As you all are familiar with the term, we call it as 12 lead ECG. Have you ever thought about it that when we have only 9 electrodes, how come we have 12 lead ECG? When we have only 9 electrodes, these are placed on the different parts of the body, arms, leg, and the heart, or the chest. Then how come the 9 electrodes give us information about 12 leads or 12 sides of the heart? So I will tell you how. First of all, you have to know that we have limb leads as we have limb electrodes. So limb electrodes give us information about these 6 limb leads. And then there are the chest electrodes, 6 chest electrodes. So 6 chest electrodes give us information about the 6 chest leads. All right. Now we have 2 types of leads. Among limb leads and precordial leads, or you can say the chest leads. Precordial leads also known as chest leads. All right. Okay, limb leads. In limb leads, we have 2 further types. One is the bipolar and other is the unipolar. Now I will first tell you what is unipolar, and then I will tell you what is bipolar. About unipolar. Unipolar, as the name indicates, it's very clear. Unipolar. Unipolar means single pole, single electrode. All right. They don't need 2 poles. They don't need 2 poles. Then there are the bipolar. Bipolar means it needs 2 poles, 2 different sides like negative and positive, and current will flow from here to here, and it will record it. So these are the 1, 2, 3 are the bipolar leads, while AVR, AVL, AVF, and all the chest leads ranging from V1 to V6, these are unipolar leads. I will show you how the electrodes record these 12 leads. Okay. Moving on, ECG leads represent which side of the heart? First of all, you should know what the lead is actually. Is that slide? Okay, first let me tell you that what are the leads. Okay, now leads are basically different viewpoints looking at the electrical activity of the heart from the different sides. Now I will show you a diagram and you will be like, okay, that's how the ECG is being recorded, or that's how the ECG get recorded. Now look at this diagram, look at this picture of a catwalk. Why I'm showing you this? Okay, now if you just imagine that these moving models are actually not models, this is the electrical activity that is going from one side of the heart to the other side and then going back. So this is the electrical activity in the myocardium, and these people sitting here, these are the leads. What are the leads? Basically, they are capturing the picture. All right. Now, this person sitting here can only look the front of this thing, and he or she cannot have the information what's going on backside of this. All right. Same goes here. This person cannot see the front of her, but he can see the back of her. He can see the back of her. While this person sitting there He can or she can see the front of her, but he cannot see the back of her. Okay, if you consider the leads as cameras, we place we place red, or the limb leads are here, yellow one here, and we place F, the foot, the inferior one on the feet, and then the black one here. The black one is neutral, so we will not count it. Now we have three electrodes, red, yellow, and green. Actually, this one will be left, and then this one will be the foot or inferior, the inferior electrode. Now, what's going on here? Okay, kindly pay attention because this is very important one. I'm telling you about, first I will tell you about the unipolar leads, and then I will tell you about the bipolar leads. Now, how they record the unipolar leads. This is the right electrode. All right, this is the left, this is the foot. Now, the right electrode is looking at the heart from the right side. The left is looking at the heart from the left side, or you can say looking at the activity, or just capturing the activity, recording the activity of the heart, while the foot, the inferior electrode that we place on the foot, it records the electrical activity in the heart from the bottom of the inferior of the heart. All right. So this electrode doesn't know what's going on here. It doesn't know what's going on here. Okay. Now, this is placed on the right side. So it will give you information of the right lead. That is basically AVR. The right electrode will give you information about the AVR. R for right. All right. Okay. When we place the left electrode here, it gives you information about the AVL, that is on the left side. It is looking hard. The left electrode is looking at the heart on the left side, from the left side. It gives you information, or it records AVL, that is also on the left. Okay. Coming to the inferior or foot electrode, it's looking from inferior side of the heart. It's looking from here. It's recording the activity from here. So it gives you information. Oh, sorry. All right. This one. So it gives you information about the AVF. These are the three unipolar leads. Okay. We have AVR, AVL, AVF. These are recorded by right, left, and inferior electrodes. Okay. These are the unipolar. Now let me take you back here. Now, how do we record 1, 2, and 3? Now, this is a bit complicated, but just stay with me and focus, and I hope you will understand. Okay, now coming to 1, 2, and 3. These are the bipolar. That is lead 1, lead 2, and lead 3. And let me draw here my electrodes again. This is right electrode. This is left electrode. And over here is our foot or inferior electrode. Now, how do we capture lead 1? Okay. First of all, let me explain you the anatomical axis of the heart. The anatomical axis of the heart is lateral and inferior. Can you see that? This is inferior and lateral towards left. Heart is not lying flat. Heart is not lying in the chest like this, not totally vertical or downwards. Heart is lying in the chest downwards and lateral. So if I say the anatomical axis of heart is infralateral, so I may not be wrong. All right. The anatomical axis of heart is infralateral. As you can see, it is lying inferior and lateral. First thing is that. Now, secondly, as the anatomical axis is infralateral, so does the electrical activity. The flow of the electrical activity in the heart is also inferior and lateral. Got it? Inferior and lateral. So anything that is recording the electrical activity of the heart from the right side, so how it will see the electrical activity? It will see the current flow going away from it. And those leads those are placed on the left side or inferior side, they will be recording the electrical activity of the heart. How? As the current is flowing towards them. All right.
Now I will tell you how the lead 1, lead 2 and lead 3 are generated. What is lead 1? Lead 1 is actually the current flowing from the right electrode to the left electrode. Lead 1 is actually the current that is flowing from right electrode to the left electrode. Lead 2. Lead 2 is actually the current that flows from right electrode to the foot or the inferior electrode. And lead 3, it is actually the flow of current from the left electrode to the foot electrode. Okay, got it?
The chest leads. So this is another diagram that I have drawn for you. So it is already drawn here. The right, left, and L means the inferior lead. Okay. So they have already mentioned that it's the when the current flows from here to here, it gives you lead 1. When current flows from right to foot, inferior side, it gives you lead 2. And then when current flows from left to the inferior side to the foot electrode, it gives you lead 3. So that's good. And that's this simple elaboration of it again. Now, this is very interesting. Uh, Bipolar leads was a bit tricky, but the unipolar leads are very easy. Now, the unipolar leads of the chest. Now, unipolar leads, how these are produced or how these are generated. As you know, as the name indicates, V1 electrode, V2 electrode, and V3, V4, V6, V6. They gives you lead V1, V2, V3, V4 as their respective names. So what they do? Now, as you can see, V5 and V6 are placed on the left side of heart. So they will give you information about the left side of the heart. Cool? All right. These are placed near the septum or the front. So they give you information about the front of the heart. That is the interior. Now V1, V2, they are placed here. Not only they give you information about the right side, but they also gives you information about the septum of the heart. The septum of the heart means the myocard, the electrical activity going on inside the septum. These will give you information about the anterior chest. Anterior chest means the interior wall of the heart, I mean. And then V5, V6 will give you information about the lateral wall of the heart. This is P wave. Then this is PR interval. This is Q. This is R. This is S. This is ST segment. This is T wave. And then this is U wave. Okay, this is PR interval. This is QT interval. We will go through these one by one. Okay, just briefly, I will tell you the very basic of the what you call the conducting pathway of the heart, you can say. Okay, we have SA node. Electrical activity generates here automatically, and it just stimulates the atrial muscles simultaneously. They contract. It passes on to AV node, forwards this electrical activity to the bundle of His. It goes to left and right bundle branches, which then ultimately reaches the ventricle muscle mass, and it contracts. Okay, simple. This is very interesting diagram. Okay, now you can correlate it with the cardiac cycle. But the more important part I want to tell you is that if you can see clearly up till here, this dark brown or orange color, this part is, it shows this part of ECG shows atrial activity, atrial contraction, while this side of the ECG gives you information about the ventricular contraction or ventricular side of the heart. So this is very interesting. Again, this side of the ECG gives you information about the atrial contraction or the atrial activity, while this side gives you information about the ventricular activity. Okay. If we talk about P gives you information about the atria. And when we talk about QRS complex, it gives you information about the ventricular contraction or ventricular activity. As I have told you already, that P wave is generated when the atrial depolarization occurs, which means atria contracts, it causes formation of P wave. Then there is a delay at AV node. From SA node, the current reaches AV node. There is a little delay, which is represented by this segment, this line. Okay. Then ventricular depolarization. When the current reaches ventricular wall, it contracts. When it contracts, it gives you the wave of QRS, that is known as QRS complex. Okay, what is T wave? It is the last part of the cardiac cycle where ventricles start repolarization. When they repolarize, it gives you information about the T wave, and this the last straight line, also known as isoelectrical line. It shows you that for few milliseconds there is no electrical activity, and then again cardiac cycles starts. See here that lead 2, 3 and AVF. These give you information about the inferior wall of the heart. Now lead V5, V6, as I have mentioned, these are placed on the left side of the heart. AVL, as the name indicates, it is present on the left side. And 1, it is also the lateral leads. Okay. Then V3, V4, these are the anterior. And V1, V2, these are the septal. Okay, about P wave. P wave, as I've already mentioned, that it is generated when atria contracts. So when atrial contraction occurs, P wave generates. Now its shape should be normal. Like, what's the normal? I will tell you what's the normal is duration and position. And it may be absent in atrial tachyarrhythmias like atrial fibrillation and SVTs. It may be inverted when the electrodes are wrongly placed or misplaced, dextrocardia, or AV junction rhythms. P wave can be tall, that means its shape will be abnormal. If it is more than 2.5 small squares, tall, more than 2.5 small, it is known as tall. And if it is more than 2 mm or 2.5 small squares wide, it will be called as wide when it is more than 2.5 small squares. This is the normal shape. In the normal shape, we will say P wave should be rounded tipped. It should be like rounded, not peak, not tall, not like this. It should be like rounded, a normal round shape. What is P pulmonale and what is P mitral? P pulmonale actually is a tall P wave. And what is P mitral? It is a wide P wave. And what is wide P wave and what is tall? Tall. Tall means it is more than 2.5 small spheres, or you can say more than 2.5 millimeters. When it is more than 2.5, it is tall and we call it P pulmonale. And as the name indicates, pulmonale, pulmonology, it gives you information about something going wrong in the lungs. All right. And what is wide? When P wave is more than 2 mm, and somewhere it is written that it is more than 2.5 mm wide, we call it mitral. And as the name indicates, mitral, it gives you information about the left side of the heart, left atrium, left atrium. Okay. P pulmonale will give you information about the right atrium, and P mitral will give you information about the left atrium. I have tried to show you P pulmonale. These are the large squares. Don't take it as small square. These are the large squares. And then there's again, this is the tall P wave, also known as P pulmonale, known as P mitral. It is wider, more than 2.5 small squares. Now, The important thing is, I want to tell you here that when you have to look at P wave, you have to look at the P wave in lead 2, and then you have to confirm the abnormality in lead V1. I will repeat again. When you're looking for a P wave pathology, first look in the lead 2. If you found, or if you find that the P wave is abnormal in shape, then look at it in the lead V1. Confirm it in lead V1. If it's abnormal there, then it means your diagnosis or your suspicion is correct. I have already mentioned that you have to look into lead 2, and then you have to confirm the abnormality or pathology of P wave in lead 1. First, we will go for the normal scenario, then we will go for the right atrial abnormality, and then we will go for the left atrial abnormality. Now, this is a normal P wave in lead 2. It's a normal shape, normal size shape, and the rounded tip, okay? And sometimes in V1, you can see P wave as you can see it here, biphasic, or you can see it just like normal P wave. When there is right atrial abnormality, you will be having a P pulmonale, a tall P wave in lead 2. And when you want to confirm it, you have to look into the V1.
Now in lead V1, in the first half of the P wave, it will be more prominent than the second half, which shows right atrial enlargement.
When you find this type of P wave in lead 2, that is P mitral, the wider one, more than 2.5 mm, you have to confirm it in V1 lead. Now here, the other side of the notch will be deeper. Got it? This side will be deeper and this side will be shorter. So it will indicate that the left atrium is enlarged or dilated. Okay, now let's move to PR interval. It gives you information about the whole atrial electrical activity. Normal duration is this, as you can see, and it can be prolonged in AV blocks. PR interval can be short in these situations like WPW and LGL syndrome. This is a normal PR interval on the picture on the top, and picture on the bottom, you can see the PR interval is prolonged. As I mentioned, it more than 5 mm or more than 5 small squares. So you can say the PR interval is prolonged. This is also another ECG, not very good, but at least it's showing a prolonged PR interval. Now about the Q wave. Coming to Q wave, about Q wave. Okay, people may ask that Q wave, can a Q wave normally be present? Yes, it can be present normally. And if it's there, maybe it's normal. When we say it's not, when we say the Q wave is pathological or abnormal, when that's when it is wider, more than 1 mm, or it is deeper, more than 2 mm, or it is 1/3 of the R wave. Let's say this is R wave. Let me use another marker. Okay. Let's say this is Q wave. This is R wave. If the Q wave is 1/3 of R wave or more than that, we will say it is significant. It's pathological. Okay, then it may be present with MI. Maybe usually it is present with MI, in LVH, in bundle branch blocks. And sometimes in lead 3, when there is pulmonary embolism, Q wave is usually can be seen in lead 3. This is a very small, tiny Q wave. This is normal. If you see Q wave like this is normal. This is deep, more than 2 mm. So it is abnormal. Now here you can see there is ST elevation, and plus there is a deep deep Q wave. A deep Q wave with ST elevation means it's pathological, it's abnormal. You have to be concerned about it. Now, QRS complex. It shows ventricular depolarization, as I have already mentioned. Shape is important. Duration is very important. It should be less than, lies between 2 to 3 mm. And this is the duration in time, 0.12 seconds. When you say it is too tall, when there is hypertrophy, sometimes it's too tall. R wave or S wave, more than 25 mm or 25 small squares. If R wave or S wave is more than 25 mm, you will say QRS complex is too tall. Too small, it may be seen in pericardial effusion. It can be too wide. It can be too wide in bundle branch blocks or arrhythmias. Too narrow. It can be too narrow in incomplete bundle branch block or WPW syndrome. Now, these are different shapes and morphologies of the Q wave. Q wave can be seen like this, that is normal. Q wave can be absent, it's also normal. Yeah, Q wave can be seen like this. This is a common finding when patient is having some old ischemic changes. So that patient will have QS pattern. That is very common. Okay, over here, Q wave is deep. It is more than 1/3 of the R wave. So it is also, this Q wave is pathological. So these are the different shapes, morphologies, pathologies, whatever, of the Q wave. QRS complex, sorry. This is a horrible diagram of a wide QRS complex. It's not too good. Okay, these are the good ones. This is a slurred QRS complex. This is normal. This is slurred and this is broad. As you can see, this is broad. So this is abnormal. This is abnormal. This is abnormal. And this QRS complex is abnormal. Now, ST segment, it's very easy. Either ST segment is normal, touching the baseline, or it may be, what you call it, ST segment elevation, or there may be ST segment depression. Now, there are different shapes or morphologies of ST segment. Okay, first of all, ST segment shows early part of ventricular repolarization. Usually it is isoelectric. It should be isoelectric. So isoelectric means it should be flat. It should be like this. Not like this, not like this, not like this. It should be like this, straight. That is isoelectric. Okay, it may be elevated in STEMI, in Prince metal angina, pericarditis, aortic dissection. It may be depressed in non-STEMI. Drugs may cause depression of ST segment, like antiarrhythmic drugs may cause it. And then there's electrolyte abnormalities, which may lead to a depressed ST segment. These are the different shapes. This one is normal because it is touching the baseline. This is elevated. As you can see, this PR interval is actually the baseline. So this is elevated. This is depressed. These are the different forms of ST downsloping and upsloping. These are also not normal. This is upslope. This is a depressed ST segment. So these are the different shapes and morphologies. Coming to T wave. T wave shows a late or complete repolarization of the cardiac cycle. Shape is very important. It may be inverted. When it is inverted, okay, the inverted T wave may be normal in lead AVR or lead 3, or sometime in young people in lead V2, T wave may be found as inverted. And sometimes pathological T wave inversion can be seen in ischemia, hypertension, left ventricular hypertrophy, and again, famous electrolyte imbalance. T wave can be too tall and T wave can be too small. Reasons: acute MI or hyperkalemia, like more potassium, it may lead to too tall T wave, and then it is too small, hypokalemia, pericardial effusion, hypothyroidism, and there's a long list that may lead to a formation of small T wave. These are different shapes and morphologies of T wave. All right, let me show you this normal. This is a biphasic. This is notched. The most important one for me, which I want to show you, these two ones. Yeah, I want to show you these two ones and I want to explain these. Now, when you see there's T wave inversion, you have to see the shape of T wave inversion, the how it is inverted. Either it is symmetrical. Can you see? This is symmetrical T wave inversion. This is known as symmetrical T wave inversion. It is present in ischemia. Now there's another type of T wave inversion that is very important. And usually we just find it in the patient with hypertension, long-standing hypertension, which may lead to left ventricular hypertrophy, and it just presents as strain pattern, also known as strain pattern. In such cases, we have asymmetrical T wave inversion. Now, what is asymmetrical T wave? T wave. This is a symmetrical T wave inversion. It has both rounded shape. Okay. Now, I will try to draw it for you. And then there is like this. Now, see the abnormality here. Can you identify? This side is straight and this side is curved. Okay, again, this side is straight and this side is curved. It is known as asymmetrical T wave inversion that is very common in strain pattern in long-standing hypertensive patients who have left ventricular hypertrophy. I just want to elaborate these two T wave inversions to you. QT interval, total duration of electrical activity. Okay, QT interval. It shows the total duration of electrical activity in the ventricles. PR interval was total duration of electrical activity in the atria, and QT interval, it is the total duration of electrical activity in the ventricles. It may be too long, it may be too short, it is a duration 0.43 seconds, and less than 0.35 seconds means is too short, and different electrolyte abnormalities or different drugs can cause these changes. Progression of waves in different leads. Okay, what is the progression? It means that there may be positive deflection and there may be negative deflection. Then there is very important, the progression of R wave and then regression of S wave. There are some isoelectric waves. Okay, what are these? I will tell you. And most importantly, which leads are the right ventricle and which leads are the left ventricle means that V1, V2. Whenever we'll talk about the right heart, right ventricle, we will look at the V1, V2, and when we will be talking about the left ventricle or the left heart, we will be talking about V5 and V6. Okay. Ghulam Mustafa, okay, I will share my link later. At the end of this session, I will share the link of my YouTube channel. Okay. Yeah, that is CAPS by Sairah actually. All capital CAPAS. Okay. Now, positive deflection, negative deflection, progression of R wave, that is very important. And just keep this thing in mind. When we will talk about right heart, right ventricle, we will talk about V1, V2. And when we will be saying that we are talking about left heart, left ventricle, you have to look at V5, V6. Now, how do we have a positive deflection and when we have a positive deflection, and in which lead we will have a positive deflection. For that, again, you have to go back to this slide. I will take it one by one. Now, as you can see, that in lead 1, lead 2, lead 3, and except for AVR, in all the limb leads, normally, in normal patient, we will have a positive deflection. Okay, this is also positive deflection. What do you understand by positive deflection? Positive deflection means R wave will be tall and S wave will be short. So we will call it positive deflection. And when we will say negative, when there is a small R wave and a deep S wave, we will call it a negative deflection. Now, why we have a positive deflection in all these limb leads and but not in the AVR? Why in AVR all the leads, all these waves are negative, are downwards? Can you see this? P wave downward, deep S wave, that means there is a negative deflection, and then there is inverted T wave. Why all these waves are negative in AVR, and while these all are positive in all other limb leads? For that, we have to go back to this very important slide. Now, let's see here. Okay, as I have mentioned that we have a positive deflection in all these leads. In all these leads. In AVL, we have positive. In V1, in lead 1, lead 2, lead 3, AVF, we have a positive deflection. While only in AVR, we have a negative deflection. Okay, anyone among the participants, can anyone just tell that why the R wave is negative? Or you can say, sorry, we have a negative deflection, or we have a deep S wave in AVR, but all in other these leads, we have a positive deflection. Why? Someone is telling, Nasir is saying, current is moving away, current is traveling away. Yeah, great. Jennifer, because current cardiac axis is infolateral. Good, great, Jennifer, exactly. Abdullah, yes, everyone, Nasir, Sahar, Anas, action potential is moving. Great, you all know? Yeah, that's cool. Okay, everyone knows. Yeah, that's the right answer actually. Okay, like over here, as I have told you that the for those who still couldn't understand it, let me explain it to those. That as I have mentioned earlier, that anatomical orientation or anatomical axis of the heart is downwards and left. That is also known as infrolateral. Okay, infrolateral. So as the anatomical axis of the heart is infralateral, so does the electrical activity or the flow of current. Of course, the flow of the current also goes downwards and infralateral, because the AVL actually is actually the activity or the electrical activity of the left side of the heart. So in this lead, the current flows toward it. Again, lead 1 is on the left side. You can say the current flows toward it. Same goes for lead 2. AVF is, these three leads are inferior, lying inferiorly. So in these leads, there will be a positive deflection. While in AVR, it is on the right side, totally opposite to the axis of the heart. Right side. So for this lead, the current is flowing away from it, downward and lateral. And this lead is on the right side. Because the current is flowing away from this, so there will be a negative deflection on ECG. So let's go to the chest leads. Now in chest leads, now you will tell me that, okay, now this is your little test. Now tell me, Would there be a positive deflection or negative deflection in lead V5 or V6? These are the left leads. V1 and V2 are the right leads. I have already told you that these two will give you information about the right side of the heart. These two leads will give you information about the left side of the heart. And these two will the interior side. They are lying in the center. Now you will tell me. First of all, tell me that what will be the deflection in V5 and V6? Now come on, inbox me. Okay, the answers is coming in very fast speed, in a very rapid. Positives, positive, positive. Yeah, it will be positive. Abdullah, Alina, Seher, or Sahir. I don't know. It's Sahir or Seher. It is Shirvani. Okay, good. Positive, good. So great. Rabia, Saima, everyone is saying positive. Very good. Excellent. Exactly. Because these two leads are on the left side. So in these two leads, there will be a positive deflection. Means R wave will be prominent and S wave will be small. Now coming to this, because lead V1 and V2 are on the right side of the heart, so in these two leads, there will be a negative deflection. Negative deflection means S wave will be deep and R wave will be small. Now, what happens to V3, V4? Because they're in the center. They're in the center. So in these, there will be, we will say, both the deflections will be of equal size. In lead 3, V3 and V4, R wave and S wave will be equal. Okay? Does this make any sense to you? What you already know now is that in lead 1, because these two are the right leads, so there will be a negative deflection. Negative deflection means a prominent S wave and small R wave. V5 and V6 are the lateral leads, so there will be a positive deflection, means a prominent R wave and a small S wave. V3 and V4 are the center. They are in the center of the chest or center of the heart, I will say. So there will be there will be equal R wave and S wave will be equal in these two leads. Oh, that's the end of my lecture. Okay, up till now, if you could not understand anything, just ask me. I will answer you. And today we have reached the end of our session. Tomorrow we will be doing the practice of the how to calculate the rate, how to identify the rhythm, and then there will be other abnormalities of the ECG. We will just go through them one by one tomorrow. Same time, 9 p.m. to 10 p.m.